Good evening, everyone. Welcome to the Psychiatry Redefined webinar series. I'm particularly excited for tonight's webinar. I've been wanting to do something on neurofeedback for a while, and now we're doing it. Yay! And I'm particularly happy that we are having Dr. Kakaiya do it with us. And speaking of, it is my pleasure to introduce to you Dr. Divya Kakaiya. She is clinical director and founder of Healthy Within treatment program in San Diego and has been treating brain and psychological conditions since 1983. In addition to her doctoral degree, Dr. Kakaiya received a postdoctoral Master's of Science in Psychopharmacology in May of 2011. Dr. Kakaiya's center incorporates treatment modalities that are on the cutting edge of brain neurocircuitry, gut-brain axis, and biochemistry issues. As an integrative psychologist, she's been utilizing neurofeedback in her treatment center for the last 7 years and sees tremendous progress with all of her patients who range in age from 4 to 88 years old. She's becoming a foremost expert with integrative treatments for traumatic brain injuries and PTSD. And tonight, Dr. Kakaiya will be discussing using neurofeedback for trauma resolution. Please welcome Dr. Kakaiya.
Thank you, Heather. Thank you so much. Thank you. It's wonderful to be here, and it's wonderful for me to talk about my passion, as Heather mentioned. And it's so funny, Heather, I need to update my bio because I've been doing neurofeedback now for 11 years. And so that's just the thought that went through my mind as I was telling you that. So this is kind of exciting, very exciting for me to be here and to share the amazing, tremendous gift that neurofeedback is going to be bringing to many of your patients as you consider expanding your clinical skill sets to include neurofeedback in your practice. So I'm utterly thrilled when Heather had contacted me and we set this webinar up. So this is great. I'm going to be covering a few topics, and I'll just go into my next slide and kind of let you know that the primary conflict of interest I would have at this point here is that because of my love and passion for neurofeedback, about 2.5 years ago is when I decided that I was going to launch my business into the next stage of my business, which is teach clinicians like yourselves, all of you that are here, one, the powerful impact that neurofeedback has on the brains of our patients, and two, make it so incredibly easy for you, because a lot of practitioners I talk to get very overwhelmed with the idea of how they're going to be adding neurofeedback into your practice. So the conflict of interest that I have is I will be talking about my franchise at the tail end. I'm not going to spend too much time on that because the bulk of what I want to do is really excite you about what can be done with the brain with neurofeedback. So kind of keep that in mind. And then I do not have any kind of a stake in any company that sells neurofeedback equipment or anything like that. So I remain very independently in terms of the choices that I'm making with what equipment comes into a neurofeedback treatment center if you choose to add that into your practice down the road here. So, you know, as Heather mentioned, background in clinical psychology, definitely consider myself an integrative psychologist. And of course, you know, where my community is in integrative medicine for mental health. That's IMMH is my most favorite conference I go to, and I always look forward to that. Ran an eating disorder clinic, and when I was running that eating disorder clinic, I incorporated neurofeedback in there, and then realized that my patients who were actually severe anorexics, bulimics, binge eating disorder patients, that when I added neurofeedback into the practice, and the ones who are on neurofeedback were starting to do a lot better, because obviously the underlying conditions of anxiety and depression, mood disorders were being treated. So that made a huge difference. And I pivoted to totally into neurofeedback as of 2010. Do not consider myself in the eating disorder world at all. I try to keep divorcing myself from it. But you know, when you've done that for 25 years, it tends to follow you. And then I have that master's degree. And currently it's kind of overwhelming, nerve-wracking, as you all know, studying for the PEP exam, which would allow me to become a prescribing psychologist in the state of California, in a couple of years, when the state approves, we're moving quite up the road. We should be able to do that. So, and just have been very passionately conducting neurofeedback for 11 years now. So I have a little bit of experience under my belt with this particular treatment modality. And that's all I do in my clinic. I have 5 neurofeedback machines. Probably about 30% of my time is psychotherapy. And we win a lot of family therapy in there because I love doing family therapy. But primarily, my day is spent rewiring brains, and with a lot of joy and excitement and the shifts that I see with that. So what I'm going to do, as I talk today, just a little bit of, I'll talk about the impact of trauma on the body and the brain. Obviously, we all know it, but I'll be talking about it in terms of regions of the brain, a little bit about the anatomy of the trauma. And I'll spend quite a bit of time giving you the science behind why neurofeedback works. That's a very big part of it, because I know when I went to graduate school, did not know about neurofeedback, did not hear about it, only really got exposed to it when I was in my postdoctoral program, because the university I went to here in San Diego has a very strong behavioral component to their PhD programs now. And that was where I got my postdoctoral degree. And it was at that point I got exposed to neurofeedback, and kind of actually came into the world of neurofeedback through my son, who has an inattentive ADD brain. And I didn't want to be putting him on any meds. I just knew from the time it was first, second grade that I was going to be needing to do some work over here as he got older and the hormones were going to flow through his body. So, kind of came through that. The other part, I'm going to talk quite a bit about how neurofeedback works. We've got a ton of studies. I'm going to be sending Heather a very nice bibliography of all the research studies that were created with neurofeedback. And then she's going to email those to you all when you receive the recording of today's webinar. So she'll get that. And this was made very recently, about 3 weeks ago. So there's a ton of really recent 2020 studies in there. We're starting to do more double-blind studies and all of that. So, and of course, I'm going to talk a little bit about an easy way to bring neurofeedback into your practice. So, when we look at neurofeedback, we all know the manner in which the quality of our patients' lives gets impaired, right? Now, we also know that the spillover from trauma has become a very significant health problem. All of us have patients, if I were to venture a guess, how many of us have patients that have trauma in the history? It's going to be way more than 50%. Most clinical practices will have that. So, and we also know trauma is kind of complex to treat because we have these comorbid conditions that come along with trauma. And we've got depression, you've got anxiety, you'll have your co-occurring addictions. And with weed being so prevalent now, a lot of patients will be self-medicating in those ways. You'll have a lot of patients who have self-harm issues. So with trauma, what comes along with trauma is a brain that's a very dysregulated brain. So we want to be thinking about trauma, dysregulated brain. And, we know that typically, anytime you try to do any kind of exposure therapy or different treatment modalities, that there tends to be a very high dropout risk for patients with trauma. And they'll go, searching for different practitioners, and they may go hopping because they're really looking for that stable attachment, but the brain is so dysregulated. It's not that we end up wanting to go to access to stuff and everything. And I'm very much about, as much as possible, let's kind of keep that out of the picture, because we want to be looking at this brain as a very dysregulated brain. And because, Bessel van der Kolk always talks about all trauma is non-preverbal. So we know that most of our therapies that we tend to have for trauma involve like talk therapy. EMDR is different, but most other therapies involve talk therapy. And then if the trauma is so embedded in the brain that our patients don't even have kind of like the feeling words to describe what goes on for them, then some of what we'll be doing with them is really going to be very ineffectual. And then medications can only take them so far. And so that's where you'll see how neurofeedback is going to be an incredibly powerful modality for you to be thinking about as an adjunct that you add either to your own practice, or you look for neurofeedback practitioners in your area that can co-treat your patient, and you'll see the amazing changes that'll start to happen with your patients. So they do drop out of treatment. And then we also know that the whole body trauma memories are centered in the limbic system, and they tend to be inaccessible to processing and resolving them via cognitive faculty. So if you're already stuck in that emotional limbic system, to be able to pull forward your prefrontal cortex and do some of that cognitive work, that often becomes really hard for patients with trauma. So that's one of the reasons why they can be very challenging patients in our practice, and they can be very complex, and they have these multiple comorbidities. So it becomes quite a case that can be very, very complicated for most of us. I think the other piece that I'm thinking about is that we really want to be able to incorporate thinking of, I keep coming back to COVID. Like, we all know, for example, for those of us that work with any teens right now, every family that we're working with right now pretty much has a teen who has been so dysregulated this whole year that the trauma of what are we going to do with the rest of our school year right now, it's probably in many of our practices right now. So we want to kind of keep in mind societally what's going on for us, and then everything that has happened in our country through BLM and the racial justice movements. There's just the soup that we've been stirring up in for this last 19 months, year and a half. It's going to be pretty intense as we come out of it. And we also know that typically when somebody's experienced any kind of a trauma, it takes about 6 months before we start to see some of the real symptoms of that trauma. So as we open up more and we start trying to get out there into the world, I think all of us that are practicing medicine right now, we're going to start seeing much more complex psychopathology that's going to be showing up in our practices. So, just a little update on our frontal lobe. And I like to present that brain mapping because, we're going to be, our sensors sit on different regions of the brain. So it's really important for us to think about when I'm doing like a T4P4, for example, on a patient, I'm really in that parietal lobe and I'm in the temporal lobe. And there's language, there's understanding, there's memory. And then making our sense of ourselves in the world is very much your parietal lobe. So, how am I moving about in the world? Am I frozen? Have I not left my apartment, for the last 6 months? And where am I with all of that? And then how am I experiencing the sensory parts of the world? So I like us to be thinking about the different lobes of the brain as you think about neurofeedback and you think about trauma. My mind's always thinking, like, I'll be sitting here with a patient and I'm thinking, what lobe am I in? What am I doing next? So it just becomes different, just as for many psychiatrists, you're thinking, okay, which other, SSRI can I add in here? What else can I do? I'm usually thinking in terms of what lobe am I working with? What am I needing to do? I have a really complicated young man I'm working with right now who is schizophrenic. He's very stabilized with his schizophrenia. He's on, appropriate dosage of medication and everything, but had a lot of negative symptoms. And so he's come probably for about 25, 26, 28 sessions now. And the parents are blown away because he's coming into his world with memory, with clarity. He's engaging with his peers now. He's talking, he's going out. He's not in his little isolated shell. And this is after 22, 26 sessions or something like that. But he's really forming that. He's sensing that there's something that's shifting in his brain. And much of what I do with him is I do a lot of T3, T4, which is the stabilization. It reduces the dissociation in the brain. I'm doing a little bit of frontal here, and then I do FP1, FP2. So I'm doing a lot of frontal lobe work with him, and then a tiny bit of T4, P4. And the reason I'm not doing too much of that is because I don't want to disinhibit him, because this technology is very powerful. It can be very easy for us to disinhibit a patient or over arouse a patient. So it's like the bell curve. You sort of have to be in that sweet spot when you're working with your patients, and really develop that as you get to know how to do neurofeedback, and as you get to know your patients and you know progressively what you're working on. So when we, think about trauma, amygdala obviously is the core part of it. It's, the amygdala is our brain's stress evaluator, and it decides, the amygdala is the one that's going to decide when to react. So when the trauma occurs, what's happening in the amygdala is it sends out that danger signal. It gets overactivated. The amygdala is, oh my God, there's some stuff going on over here. What am I going to do? And then the amygdala is the one that's initiating your fight, flight, freeze. And I always add fawn. We kind of forget about the fawn because those are our people pleasers. Those are the people who go into like a pleasing mode, right? So think about, particularly when we're dealing with complex trauma, many of our patients may not present your classic fight, flight, freeze symptoms. They may present a fawn where they really over accommodate and they people please and they yield to the other person's directive and all of that. So what the amygdala is doing too is it's storing stimuli that are associated with memory, such as the sights, the sound, the smells. So that's why our patients will talk about, when a particular traumatic event occurred for them, they distinctly remember the smell in the room, or they remember a siren going by, or they'll have like certain memories that are embedded in the brain, and those are all embedded in your amygdala. So amygdala is the core, emotional core of the brain. And then the amygdala's job is to produce calming thoughts that tell the rest of the brain, the prefrontal cortex, that, hey, it's okay, there's no danger out here, we can get out there. But we know that with traumatized brains, many of them get stuck, frozen in the amygdala. So what we see, some of the signs that we see with traumatic stress in our patients is we'll see anxiety. The one that, oh my gosh, responds so well to neurofeedback is hypervigilance. Because remember, if the amygdala is like constantly scanning the environment, if it's constantly scanning, then the amygdala is not going to let go and say, oh no, we're safe. So that hypervigilance tends to have a protective function to it. But the hypervigilance is also extremely exhausting for the brain. That's why we'll see our patients really tired and they just don't seem to be able to kind of like pull things together. And then, some of the other signs we'll see is that they avoid the stimuli that are associated with the trauma, the startle response. When I do T4, P4, like I have a patient I'm treating currently who was robbed 2 years ago. She's only come to me now. She's like, Divya, I don't even know why I didn't think about coming to you. And the improvement, she was constantly dropping things. She turned a corner and she was dropping things. I think I did about maybe 8 sessions of T4, P4, and I went longer because I just knew that her hypervigilance is very intense. And her startle response was very intense. About maybe 12 sessions, her brain already calmed down enough for her to have a reduction in the hypervigilance, and her startle response started to come down a little bit. And the brain will sometimes rebound back because the brain's like, we've been doing this for 2 years. I'm not sure. I don't think I want to let go as of yet. I'll decide if I'm ready to let go or not. So that excessive amygdala activity, as I mentioned earlier, and since the traumatic event is stored in memory, if any stimuli that are similar to what occurred are encountered, the brain gets triggered and they send out a danger signal. So, and the biggest thing that the overactive amygdala does is it interferes with sleep. Now, what I tell my patients when I do neurofeedback is the number one place where you'll immediately start to see some changes in your brain is going to be with your sleep. Expect to start having really intense, vivid dreams. Expect to start dreaming again, because remember, we need that REM sleep, right? So one of the best things that starts to come out in the initial stages of when we begin neurofeedback is our patient's sleep starts to get stabilized. And then guess what happens? When they start to sleep better, they begin to look at their world differently. Then a little bit of their cognitive mind can come on, and they can start to begin to assess things from a cognitive function, because the brain is receiving that rest and the brain is removing the toxins in the sleep. The hippocampus is another region of the brain that's very affected by trauma, as we all know. And we know that the hippocampus is essential to memory formation. And what the hippocampus does is it calms that overactivated alarm circuit. The hippocampus will be the one that'll say, it's okay, we've been in this situation before, don't worry, we've known how to take care of it, we're good to go, you can calm down. So because it's a storehouse of some of our memory, it's going to be able to calm down the alarm circuit of the amygdala. So we want a hippocampi that are strong. And when we have overactivation in the hippocampus, that's when we'll have confusion, because the patients will say, I have a memory fog. I feel kind of confused all the time. I feel like I'm in a daze all the time. They'll be disoriented. Like with my trauma patients, it's a common occurrence that they thought their appointment was 11 a.m. when their appointment was really at 12 noon, or they're usually, because that disorientation is part of the trauma reaction from the hippocampus that's been affected. So I tend to have a lot of patients with them, and there's always a way, especially when you have 5 machines, there's always a way in which you can kind of figure things out and meet their needs with where they may be at that point. Recurring thoughts about the trauma, the obsessional recurring thoughts. Now, of course, when you have a psychiatric practice, your mind just thinks about, oh, what other medication that I can put them on that could allow their obsessional mind to calm down. And while that can be effective, just know that those recurring thoughts are, we bring those down. We do left brain, left frontal work for that. I'll do T3 FP1, and probably after about 5 or 6 sessions, they'll say, gosh, you know what? I'm not in that loop anymore. I can tell I broke that loop. So there's a shift that starts to happen. And then the nightmares are very much a part of the hippocampus being affected by the trauma. Flashbacks are a part of the hippocampus, and difficulty sleeping, obviously, because the brain is like, nope, I cannot go down for the night because at any second danger is around the corner and I have to keep myself alert. So that's a huge piece of it. We also know, because of the studies that have been done with the brain, that brains that have experienced trauma tend to have a smaller hippocampus. So there's a significant structural, functional impact that trauma has on the brain, and the brain changes in its form as we do the work with the trauma. Okay, where's my cursor? There you are. Okay. So the frontal lobe, getting to know the different regions of the brain. The frontal lobe is our lobe, obviously, that controls our behaviors, our emotions, our impulses, and it is the center of emotional processing and decision making, right? So we know that after a traumatic event occurs, the ventromedial prefrontal cortex is the one that should let the amygdala know that it's okay, calm down, danger has dissipated. Yes, we have a memory coming from hippocampus that tells us that we did do okay. But what happens is, because there is circuitry that has broken down in the entire circuit related to this region of the brain, that the patient's not going to be able to calm themselves down. They are going to be irritable. They're going to continue to withdraw. They're going to continue to numb. They'll be very avoidant of a lot of situations. And so when the prefrontal cortex is not able to override the amygdala, the sign of danger feels very omnipresent to the patient. So it's very hard for them to get a good night's sleep, to relax, to let down their guard, to enjoy any event. So that is where trauma has such a significant impact on the whole person every step of the way. So we know when we look at, our prefrontal cortex, it's very It's it's a very significant part of our brain. It's also the place where we have that sense of humor, where resiliency lives, where we have complex reasoning that we do. So we really want a frontal lobe that's a very high functioning frontal lobe. And we want to be able to have a frontal lobe that can make decisions, stick with decisions, get tasks completed, begin a task, finish it all the way through, do some complex reasoning, a whole bunch of different things. So part of what we're able to do very successfully with neurofeedback is do a lot of activation of the prefrontal cortex to where we can bring about a lot of regulation there. So let me, what is neurofeedback? So I always like to give core basic of neurofeedback, which is, that goes by different words, and most insurance companies tend to label it as EEG biofeedback. And the diagnosis code, and I've put this in another slide of mine too, the diagnosis code that tends to give us the best reimbursement for neurofeedback is 90901. That's the one that we've all found, most of us have found that does well. A lot of people call it neurotherapy, neurofeedback, brain stabilization. One of the best ways my patients understand it really well is I describe it to them as physical therapy for the brain. Now, as a result of my practice being a very brain-based practice, I have developed, I think this is more so in the last 3, 4, 5 years, I've really developed this languaging with my patients where we talk about brain conditions. Yes, I know I'm a psychologist. I know I'm treating mental health conditions, but I find that when I approach things from the perspective of these are brain conditions, then what ends up happening is people's receptivity to addressing their mental health conditions goes up, and your resistance to treatment goes down. The other thing that a lot of psychiatrists who consistently refer to me have shared with me, that as soon as their patients had started neurofeedback, they have found that they've become much more compliant with their medication regimes and much more happier and more regulated. So think about it as a clinical application of brain-computer interface technology, which is the purpose, the aim of that is to alter the electrical brain activity associated with various mental dysfunctions. So that's my really classic way in which I like to describe neurofeedback. Where does my little guy keeps disappearing here. Oops, I unmuted myself. So what happens in neurofeedback is that the brain waves are displayed on my computer and the goals are set there. So the first thing we do is we place the sensors on the scalp and the ears to read the brain's activity. Some of the machines I have don't have ear scalps, but we have grounds, and then we place them on the scalp. They read the EEG. It gets displayed on my machine over here, and it gets fed through the interface back into the patient's brain. So what happens is when we set some goals, when the patient meets the goals, the patient receives a reward. So that's where it's an operant conditioning. The patient receives the reward. So one of the rewards I'll have on my neurofeedback will be the screen. They could watch movies, and teenagers, zero resistance. Children, zero resistance to coming to neurofeedback because they look forward to coming here, because they're going to sit here and they're watching a movie, but the brain is doing a lot of work. So when the goals are met, so one of my feedback pieces is the screen becomes super small. So when the patient is in the range that I want them to be in, then the screen becomes really big. So they get rewarded by keeping the screen big because they want to look at the movie, and then the brain is doing the work in that way. So they're seated very comfortably. It's a fun place for them to come to. This is not one of my rooms, but this is what most of my rooms look like that. Now I have these plastic shields. And by the way, I never remained closed during COVID because I had a lot of complicated patients I was working with. And I just have room cleaners and all kinds of extra safety measures we did. So look at all the treatment conditions that I'm able to help with neurofeedback. So when in my past world, when I treated eating disorders, anorexia, bulimia, and binge eating disorder, those were my 3 conditions I treated, right? Now I'm able to treat epilepsy. I can treat OCD. We treat tics. I treat a ton of people that are on the spectrum. I treat a lot of concussions, balance conditions. I have a patient I'm treating right now who has tinnitus, learning disabilities, ADHD. ADHD is like a regular, that's a lot of people come to us for ADHD. And typically I tell people that generalized anxiety disorder, like just anxiety, is one of the easiest conditions for us to treat with neurofeedback. Panic attacks. I've had patients where after about 6 or 8 neurofeedback sessions, panic attacks are fully gone and they remain remitted. So it's a very powerful insomnia is a lot of people come to us for insomnia. And these are all, this is going to be a treatment modality that you'd incorporate where there is no side effect. So the worst side effect I could ever have with a patient if I keep the frequency too high could be I might give them a headache. Other than that, because of how picky I am and my training and how gently I go with the brain and how much respect I have for the brain, I really make sure that my patients don't experience any side effects of any sort from neurofeedback. So it's a bioelectrical grounded therapy. So the way it helps is it changes the neuronal firing patterns in the brain. It changes the amplitude of the brain wave. It changes the variability of the brain wave. And the other thing it does is it enhances the communication in the brain between different regions of the brain, increases the coherence in the brain. And we know with all the research we have in the world of neurofeedback with PTSD and depression, PTSD, is that they're cortical timing issues. So we know that with neurofeedback, we're able to change that cortical timing, and changing the brain at the level of the functioning of the brain tends to have profound effects on the brain. So the cortical structure of the brain changes and it holds the change. So this is not that this is a temporary measure. When I have kids who are like younger, 7, 8, 9, even some of my teens, I'll tell my parents that once we complete this round of treatment, what I'd like you to be able to do is about 1.5 years, 2 years later, come back in for 4 or 5 refreshers, because then the brain remembers again, oh yeah, we did this. I liked how I felt when we did this. And literally when we do touch-up sessions, it's about 4 or 5 and the brain is back on track again. Brain is very smart and it wants to be well regulated. So when we think about medications change the chemistry of the brain, the electrical impulses also change the chemistry of the brain by neuromodulating the electrical impulses. So the changes in the neuronal firing equals to changes in neurotransmitter balance. For psychiatrists, that's an easier way to understand that. And what the neurofeedback does is it trains the neuronal networks. We have multiple networks. I'll talk about the networks in a second. It changes the neuronal networks into optimum self-regulating networks, thereby reducing the symptoms of PTSD while simultaneously reducing comorbidities such as attention. So I'm not just going, okay, I'm just going to work on this region of the brain and only that region of the brain is going to get better. What's going to happen is if I'm doing T4P4, sleep is going to improve. If the patient is having constipation, if they're having bruxism, that's going to settle down. They'll start to sleep through the night better. They'll feel more settled into their body. If I'm doing T3, T4, they'll have fewer migraines. If they were having migraines, they'll have fewer headaches. There's a whole bunch of different issues that get ameliorated while we're working on the PTSD. So we find that addictions, I have patients who yell at me because they want to be able to drink more than they're drinking. They're like, Dr. K, this is not fair. Now I have 1 glass of wine and I'm like feeling really overbuzzed with it. This is not cool. I'm like, oh, I'm sorry. So EEG changes. So the EEG detects abnormalities in the electrical activity of the brain. When the EEG changes, we're bringing about neurophysiological changes in the brain. So what we're doing then, wherever we've placed the sensors, more neurons are beginning to do the same thing, and we're bringing more brain synchronicity into those regions of the brain. And as that neuromodulation is occurring, the changes in the neuronal firing begins to change the neurotransmitter balances. And we all know that there are a lot of different abnormal brain rhythms that account for the disorders that we have in our brain. The QEEG that you do before you do your neurofeedback picks up the abnormalities in the brain. And we tend to have, with the systems we use, particularly the systems for the franchise, we have set protocols that get you started in rewiring those regions of the brain. So your QEEG gives you a very good idea of exactly where the abnormalities in the brain are. And we straight away go to creating protocols that assist with that. So it's very tailored. And then we can also, I mean, I love some of the systems I have because I can go in there and do some of my clinical work there and have my clinician mind come in and say, I think I'm going to add right front. So you typically will add right front after about 3 or 4 sessions. And with some of my patients, I might start adding it sooner because I can tell that when I meet the brain that this brain is going to be able to hold me being able to go to right front sooner than later. So that's your clinician piece that goes in. So what we found is so brain waves are what drive the neurons. So when the EEG changes, so does behavior, so does attention, so does mood and affect, so does emotion regulation, and so does the ability to maintain calm. One of the best things that comes out of neurofeedback is the regulation, the emotional regulation that happens in the brain. And we have the ability to maintain a calm, it reduces our anxiety, sleep and cognition start to improve. So when the EEG changes, you're having all of these positive changes in all these other areas. So here are normal adult brainwave activities. You've got your beta, you've got your alpha, you have your theta, you have your delta. And what I find is that in brains with ADHD, in brains with trauma, you'll have excess delta and excess theta in the brain. So what we're going to do in neurofeedback is we're going to be down training those so that we can bring around more of the SMR and the beta brain waves that allow for the brain to be more regulated and more alert, calm and alert. So your SMR is the one that's, you know, you want to be like, I'm in good SMR activity right now because I'm in readiness for action and attentive listening. For patients with trauma, the high beta tends to be extremely high in different regions of the brain where it's supposed to be certain levels, you'll find that it'll be excess high beta. So these are our different bands that we work with as we do the neurofeedback. So the way it works is, so you might have an underactive or an overactive brain, which shows up on the EEG. We're able to stimulate the EEG to reduce maybe those delta waves and increase the SMR waves. So basically, that's what neurofeedback is we assess the brain and then we stimulate it to either alert it more or reduce the over-arousal. Consequently, the inconsistent brain within itself starts to become more consistent. And we teach the brain that we're teaching the brain how to change its frequency by asking the patient to make the box smaller or bigger, or make the ship go faster or slower. So we're teaching, it's a form of operant conditioning where we're teaching the patient what frequency that they can coach their brain to go to. And once the brain goes there and we give repeated reinforcement there, then the brain holds it. That's why neurofeedback is so successful. So here are all the different regions of the brain where we place sensors. So this will give you a real good idea just in terms of, like, for example, when I'm working with somebody with not being able to pick up on social cues of others, somebody on the spectrum, I'll do T4, T6 with them, because then they're going to be able to pick up on the signals from other people. I do a lot of the F1, FP1, FP2, the frontal lobes there. We'll often do T4FZ as in coherence to bring about more coherence in the brain. That's one that really calms the brain down. The PZ in the back over there, that has been the one that really reduces the alpha asymmetry in the brain that is underneath a lot of anxiety disorders and depression. So T4PZ is a site that will often do to really calm down the brain and reduce the alpha asymmetry in the brain. So we constantly refer to a map like this as we're doing our neurofeedback, and we get a lot of training, and you would get a lot of training with knowing exactly what regions to go to. And with the way we've set up our systems, the systems will pre-tell you which regions to go to and what frequency to set your systems at. We try to make it as easy as we can for you. So here's a QEEG of an ADHD brain. That's what a normal brain would look like. That's what your ADHD brain would look like, which has a lot of excess theta. So here's that same brain that before neurofeedback, see all that excess theta, that's the red in there. And then this is after 20 sessions of neurofeedback. This is the difference that happens in the brain, and the brain holds it. This is with no stimulants in the brain, no Vyvanse, no Adderall, nothing. So the optimum conditions for neurofeedback tend to be 2 sessions a week. I make that a priority. I tell my patients you have to come 2 times a week, because what I found at the beginning, I used to do once a week, but then the brain is learning new ways of being. And if we just space it out too much, then the brain doesn't learn, and then patients get discouraged, and then they feel like, oh, neurofeedback is not working. So I found I have some patients who come 3 times a week. And remember, it's a finite therapy. So we decide at the outset, when you do that evaluation, you decide how many sessions they're going to be here for, and then it's finite. So those last few sessions, like the last 5 or 8 sessions, I like to space them out to where we go once a week and then every other week. So you're kind of doing a little bit of a spacing, but the initial chunk of the work comes at the beginning of the feedback. I always talk with patients about making it a priority, plan other things around it, because then your whole world gets that much better as a result of you keeping things regulated. And I have a habit of keeping patients like in similar spots on their schedule. I don't like moving them all around the place, because remember, part of what we're doing, particularly with the patients with trauma, is you want to become that stable object for them, where they come in here, they know they feel better, they know they're going to sleep really good that night and the next night after that. And then in another day, they'll be back over here again. And then I always tell my patients to be really well fed before they come for neurofeedback, because the brain is the most metabolically active organ of the body. And they're going to be doing brain therapy. They're going to be doing physical therapy in the room. And I want them to be well rested before they come. Typically, different regions of the country charge differently, but typically the costs of neurofeedback are anywhere from $150 to $225 to $225 to $250 per session. And so typically patients need to know that they're looking at an investment that's closer to between $3,000 to $5,000. It's a non-medication approach, right? So that's the largest number of patients who come to me here come to me because they do not want to be on any meds, and they'd rather do something that's more natural, and that we're really harnessing the power of the brain to come to you. And I still get very irritated. We've had neurofeedback around for 32 years now. And when my patients call to try to get, because I give them a super bill, so when they try to get authorizations, the insurance companies say it's not experimental. So of course I get on a warpath. I send them articles. I send them this bibliography. So there's a lot of education we have to do. And if I have to do like pre-authorizations for my patients, I'll often do that because that just helps facilitate payment from insurance companies as well. And there are many neurofeedback centers that do take insurance. So think of neurofeedback as brain exercise. That's like one of my favorite ways I like to think of it. And I would like to see it be on your prescription pad. Like I am going to suggest that you do 30 sessions of neurofeedback before we put you on this, something along those lines. I would love, after this session, I hope you could add neurofeedback on your prescription pad. That would be like a dream come true for me. And really, we've got so many technologies that are coming about now, right? So you have got TMS, you have deep brain stimulation, you've got neurofeedback, you've got TDS, CDS. All of these are FDA approved, and for me, in my mind, when I think about it, neurofeedback is the one that's the least invasive. Now, I do have another machine here where we do place the sensors in more all over the whole brain, and there's a tiny microcurrent that the brain receives. I purchased that system to treat concussions only, because that was a system that was used in the NFL study that they did with the concussions with the NFL football players. So, but all my other machines are non-invasive. So these are the neural networks that are critical when we do brain training. We've got our default mode network and the salience network, which form a vital role in forming our sense of identity, our self-concept, our perception of ourselves, and ourselves in the social and emotional world. And trauma, it damages the DMN very significantly. The DMN, default mode network, also has connections to the mirror neuron region. And these are the mirror neuron region is the one that's critical in the forming of the concept of ourself and ourself in the world. So the ACC, the anterior insula, and the anterior cingulate cortex are the major elements of the salience network. So a lot of times what I find is that people that are on the autism spectrum may have impairments in DMN. So some of the work that we do with neurofeedback goes directly to retraining the default mode network. And when you see the calming that happens, when you see your patient who is on the spectrum suddenly look at you and say, hey, Dr. K, how are you feeling today? Like you can tell, whoa, okay, this person's like waking up their salience network. Executive dorsal lateral prefrontal cortex. This is one of the other neural network that's often trained in neurofeedback. This is the one that is involved in our inability to solve complex problems, to plan ahead, to focus, to sustain attention, to regulate actions. This is also the executive network is also a significant one with memory. So disruptions in this network will produce patients who are perseverate. They're very concrete, they're inattentive, they're disorganized. So neurofeedback really goes in there to do the work within that network right there. Then we've got your social circuit network, which mediates the empathetic and the socially appropriate behavior. Now, those of you that are integrative psychiatrists already that are on this call, I'm sure many of you may be starting to think about using oxytocin, thinking about considering that. We know that, Dr. Greenblatt talks a lot about lithium orotate. We talk about that. So there are many micronutrients that you may work with that are going to be affecting these social circuits. And there's a lot of research done by Dr. Jaime Pineda, who was here at UCSD, who's done a lot of work in looking at the role of So he's done studies where he did oxytocin only with autistic patients, oxytocin plus neurofeedback, and then neurofeedback only. So when he's done some of that work, he is become super clear about the most optimum piece in working with somebody who's on the spectrum is adding oxytocin and neurofeedback, because we're looking at the networks, but we're also doing some of those empathy circuits through the oxytocin. The ACC is your affect, your feeling circuit, okay? This is the one that's doing the performance monitoring, and this is the one that's looking around and saying, where are errors going to occur? This is the one that's like, I'm ready to go. SMR activity comes within that circuit. And this system is the one that connects our emotional limbic system to the cognitive prefrontal cortex. So we do a lot of work with neurofeedback. We're in the ACC circuit a lot. Plays an important role in the integration of neuronal circuitry that with affect, feeling regulation. I mean, my parents are like, when I have my 16-year-olds I'm working with, and I'll have like a kid that's just like ripping mom's head off all the time. And after about maybe 3 or 4 weeks of neurofeedback, Mom will be like, Dr. Kakaiya, I have no idea what you're doing there, but she's being nice to me. She's calming down. She's not being so reactive. And remember, neurotherapy is neurotherapy. I don't incorporate talk therapy in neurotherapy. So what I'm just doing in the room here is working with the brain. And you see the regulation that starts to occur in the brain. So we've got a few research studies. So that document that Heather is going to send you has over 2,000 research studies on neurofeedback. And I didn't want to bore you guys with too much research, but it's very important that everybody knows that there is a lot of research being done and has been done on neurofeedback, so that it gives you a sense that there is work being done. There are studies, and obviously Dr. Bessel Vanderkolk has been one of our premier persons, who's a psychiatrist, as most of you know. He's the one who wrote the book, The Body Keeps the Score. And he's huge. I just love how he's such a believer of neurofeedback for PTSD patients. So he had done an initial pilot study. He did that. And then after that, he did this randomized control study. And he had an N of 52 subjects. And they completed 24 neurofeedback sessions, training 2 times a week. Okay, total of 24 sessions. That's all. Okay, sensor placements were like in the T4 as the active site, and they used P4 as the reference site. Now, with one of my systems I tend to use both as the active site, and I find that it's very powerful when I'm using both. But in his study, he had done T4, only one site, the T4 as the active site. And look at the results that he gets. So typically, folks that have experienced, as we all know, that anybody who's had one trauma will have an average of probably 4 to 6 or 9. His patients, I think, had an average of 9.29 different traumatic events that had occurred in their lives. And post-treatment, a significantly smaller number of patients met the criteria for PTSD. Okay. Only out of 22 patients, only 6 with 24 neurofeedback sessions, only 6 met the criteria for PTSD after 24 sessions. Significant treatment times interaction. Effect sizes were comparable to those reported for the most effective evidence-based treatment for PTSD. Significant symptom improvement, especially with people with chronic PTSD, as well as in affect regulation capacities. It's one of our most exciting studies. There was another study that was conducted with refugee experiences. So he had this same group of researchers had done one prior study of 2010. I think they'd done a study that had an N of 2. And what they did, 2017, what they did in 2020 is they repeated the study with 26 subjects in it. And they saw how they wanted to look at how neurofeedback remediates cognitive deficits in PTSD with refugees. Now we think about the developmental trauma that our children that are coming across the border. I live in San Diego, so I'm in a binational part of the country. And I just really am thinking these are children who are so traumatized that are going to grow up to be adults, and they're going to be showing up in our practices. So why don't we do the work on their brains now while they're children and make sure we get those brains rewired now, so then they don't carry all these these into their adult years. Pre and post changes were noted, and the subjects, so we had subjects, adult refugees with chronic PTSD who participated in NFT. So they had neurofeedback with trauma counseling. And then the second group was adult refugees who had chronic PTSD who were waitlisted for neurofeedback and only received trauma counseling. So you've got the variable that's separate between the two groups is one received the neurofeedback, the other one received only trauma counseling. Results. Post-therapy, the neurofeedback with the counseling group had significantly lower symptoms of trauma, anxiety, depression compared to the trauma counseling group alone. This group had an increased P3 amplitude, that's the P3 amplitude, and improved behavioral performance, suggesting the normalization of cognitive control. So we know that when our patients with trauma achieve cognitive control, that's a very significant marker for remission of PTSD symptoms. So that's one thing you kind of want to keep in mind, that when they start to achieve that cognitive control, we're on our way to them getting well and staying well. So this was a study that's just been done again by Van der Kolk last year, 2020, the impact of neurofeedback on children with developmental trauma. So when we do neurofeedback, incidentally, in our assessments, we're always looking for developmental trauma. And then there's a specific protocol that we do where we want to get some of that developmental trauma resolved first before we may even go to treating the ADHD, or we go to treating something else, because that core piece of the developmental trauma has to be treated first. This group had N of 37 children with 2 groups. Again, 24 neurofeedback sessions. Dr. Van der Kolk likes to stick with consistency. 24 neurofeedback sessions 2 times a week. Results were very promising, significant reduction in PTSD symptoms among these children. Now remember, now we're sending these children out into a world that does not have to be run by a fear-driven amygdala. Imagine when we have a sense of security in the world, what a gift our patients are receiving through neurofeedback. So these were studies that were done with frontal alpha asymmetry. We know that when we have frontal alpha asymmetry, that tends to be directly responsible for anxiety and depression. That's a greater right hemispheric activation is associated with depression and anxiety. N of 20, suppression of that alpha, frontal alpha, right frontal alpha, produced reduction in symptoms, and at 6 months follow-up, anxiety and depression remain improved. Think about that, right? When we're treating our patients with medications, you know, they stabilize, you jump up your dosage again. Then they stabilize, you jump up the dosage again. Here, we suppress that right hemispheric alpha asymmetry, and 6 months later, the symptoms have still not returned. Okay, same. This is a big group that's out of China. And what they did is that asymmetry training brought the high beta down training for patients, N of 87. Both test groups showed a reduction in symptoms. Same with this third section that was done in 2017, N of 32, reduction in negative affect and feelings. So we have now, with neurofeedback training, we have a very specific type of training called alpha theta training that we do specifically for addictions and trauma. And that's at that PZ site that I mentioned when I showed you that chart. It's at a PZ site. Now, we also do a certain type of alpha theta training that's frontal, FP1, FP2, 10 hertz, and P3, P4, 40 hertz. And we do that because what we're doing is we're really reducing the overactivation of the frontal lobe, and we want to calm the whole brain down. The high arousal of that whole brain is a tool for self-protection. We can understand that. So with alpha theta training, now what was the hypervigilance is reduced and the sleep really improves. Like sometimes with some of my patients where I've done some right side training and I've stabilized the brain, I'll go to alpha theta because there might be intractable insomnia they've had all their life. So we may have regulated the brain quite a bit, but when I add that alpha theta training, then I'm actually able to get them to start sleeping through the night, which makes such a huge difference. There was a 2007 study that was done at UCLA with alcoholics using alpha theta training. And what they found is that there were 2 groups. One group was given 20 sessions of neurofeedback, and the second group was not given any neurofeedback. A year later, the folks that had received 20 sessions of neurofeedback, 73% of them were sober a year later compared to 42% who had relapsed a year later. So this is like our big seminal, we call it our Peniston study that was done with alcoholics and the usage of alpha theta training. So what we're doing is it's done at the PZ site. We also have synchrony training that we tend to do, and we add alpha theta training for that deep-seated unresolved trauma. Recently, we've got quite a few systemic reviews that have been conducted with, RCT's total of 123 studies. Results really consistently favor neurofeedback in large effect sizes. Suicidality is significantly reduced. I have one patient who I'm treating right now. I think I've done about, I want to say 26 sessions on her. I think we're gonna pause at 40. She's been suicidal since 6th grade. She's 17. She's tried multiple different types of medications, hates being on meds, is not medication compliant. Probably about 14 sessions in, has not experienced any suicidality, and is just like a lifting of a depression that she's never experienced in 6th grade. So it's very hopeful what we see in our practice over here. Another review, systematic review that was done was biofeedback for anxiety, superior results compared to the wait list. Also, what you'll find in the bibliography that you're going to receive from Heather are a lot of studies that have been done with real-time fMRIs. Now, remember, fMRI machines are expensive. They're usually in university centers. So there are a lot more studies. And some of these studies have shown that the fMRI studies that even a one-time intervention, like one session of neurofeedback, has shown some significant shifts in the brain that last. So we've got a lot of very solid data that says this is not an experimental technology. We're good to go, incorporate it into your practice. And again, what you're going to be doing is you're adding a neurofeedback practice here that's that you're capturing. I mean, we all came into the world of psychiatry, psychology, clinical psychologists. All of us come in because we want our patients to get better. And many of, I have a ton of colleagues and a ton of friends who are psychiatrists who kind of get to a place where there's a burnout. Now, I came into neurofeedback actually at a very nice time, even in my own professional career, when I was in my mid-50s, early 50s, somewhere in there, where I'd been doing this one thing for 25, almost 30 years. And I come in and it's like a brand new revigoration of my practice and a lot of hope that I tend to feel for my patients. And so it's a well-researched, patients get well, they stay well. And the thing I do very consistently is I work very closely with all my psychiatrists that are in my network who send me patients, because what we start to do is once the brain becomes more efficient in its functioning, medications need to get titrated because the brain is actually making structural as well as functional changes, right? Less meds are always better, right? In patients, you won't be dealing with metabolic syndrome. You won't be dealing with, all the other side effects that we have. And what's really going to be neat about owning a neurofeedback franchise is your staff and you will be trained by us. Because I'm so picky about doing things the right way, I'm planning on supervising anyone who purchases a neurofeedback from me. I supervise them. So you don't even have to be worrying about supervising your technician or your master's level person you bring on, because I'm kind of anal about that. And I want to make sure that people understand that this is really complex, what we're doing with the brain. And we do not want to harm any patients in any way whatsoever. Amazing, great revenue for your practice. So you could be seeing your patients, you do your patients and you brought on a technician. You might bring on 2 technicians because you're going to do 2 missions or whatever. Extra side revenue that's going on. So even when you're on vacation, so when I'm on vacation, my technicians are usually, because my protocols are pretty set, they can be seeing the patients during the time that I'm out of town. And patients get better, they stay better, no negative side effects. Imagine no serotonin syndrome, metabolic issues, no dulling of your sex drive. And GAD is one of the easiest conditions I treat. And we make it very easy for you. We give you a lot of remote training opportunities. You're not going to have to fly or drive or do any traveling in order to get neurofeedback settled into your treatment center. And the cost is $35,000 to purchase the franchise, and the equipment is an extra $22,000. And we'll give you the company that can do that equipment cost for you and everything like that. And we've got a lot of other documents that spell out royalty fees and different things that come along with that. So Heather's going to give you that extensive bibliography that is fully compiled. If there's one book you choose to get about learning about neurofeedback, I would get this one that's edited by Hanno Kirk. I adore Hanno. He's just such a gifted clinician, gifted psychologist. And the chapters there are a number of chapters in there about integrating neurofeedback into your psychiatry practice and different things like that. And then during COVID is when I gave birth to my baby. So that's a book for lay people that talks about brain fitness and how to improve your brain and all that good stuff. So just want to be able to give you that resource. You will get copies of all of the bibliography. So that's, and Cynthia Kirsten is the person who did it. We're very grateful to her for that. So here's my contact information. Feel free to email me. I'm available. I'm also very available for any of you that may want, and we'll start coming to questions now, Heather. I'm very available for any of you who may want to find good, decent neurofeedback practitioners in your area that you want to start referring people to, because I'm very anal about what the training of the person needs to be. I know what quacks could look like and what good trained, well-trained people look like, and the certifications they should have and all of those kinds of things. So please know that I'm available as a resource for you to become user-friendly towards neurofeedback in whatever way you decide to incorporate that into your practice. And thank you for all of you that remained. Thank you. And for all of you that are going to listen to this, I hope you learned some amazing things about the hope that we can create for our patients. Yeah. Thank you so much. Okay, I'm going to get to the questions.
Right. Oh, absolutely. Thanks, Dr. Kakaiya, so much. Got a very engaged group tonight, for sure. Okay. First question is about brands of machines. Since you use several of them, can you discuss brands at all?
I cannot. The reason why I won't discuss brands is because with what I'm doing with my franchise, there's a particular brand I'm going to be using. And so I want to reserve that as kind of like business information. But there are about 6 or 7 different brands of machines. And any brand you look at, what they're going to do is, because what they want to do is they want us to be successful at neurofeedback. So most of the brands will guide you to, if you want to get trained in neurofeedback, here are the groups. BCIA is offering this training, ISNR is offering this training. So they'll tell you about our professional organizations that are offering different trainings, and they will, then you could sign up for the trainings, and the people who sell equipments usually will also have their own set of training that they'll tend to do.
Okay. Someone has a question about the lens machines and wants to know if you've had an opportunity to work with them and how they differ.
So lens is very similar to that other machine that I mentioned, the one that I have purchased, just specifically for concussion. So what's different about lens, and lens is it's a good machine. What's unique about lens is that it does give a tiny microcurrent into the brain. It's not non-invasive. Most of these other 6 or 7 that I'm thinking about are non-invasive. There's no exchange. Right now, when I'm doing neurofeedback, the sensors I place on the brain just are picking up my patient's EEG, feeding it into my software, and then I'm deciding what to feed back to the patient via the visual, the tactile, and the auditory feedback. So there are 3 sensory organs through which my patients are receiving feedback: is visual, tactile, and auditory. There's a teddy bear on your lap, there's music coming out, or your sound of your screen, or the size of your screen, or you're driving a tunnel through a spaceship through a tunnel. So,
okay. All righty. Got a question from someone who has a patient with anorexia nervosa with a BMI of 16 and refuses to go to the hospital, can someone with such a low BMI benefit from neurofeedback?
So because of my 25 years, almost 30 years of working with folks with anorexia, we know that somebody who has that low of a BMI, who's refusing to go residential, they have very strong OCD traits, right? So what I have found that because the brain is so starved of nutrition, I tend to say no to bringing on anybody that's at such a low BMI onto neurofeedback, because this stuff that we're going to be doing with their brain does not have the energy resource I need that brain to have for me to do the work. So what I would probably do is work with a psychiatrist who's integratively trained, like Dr. Greenblatt. Dr. Greenblatt has experience with eating disorders. Work with that psychiatrist, because chances are that that person, a lot of what I found is that anywhere between 13 to 26% of severe anorexics who may be kind of intractable in some ways are actually on, I call them Asperger's, I still use the word Asperger's, are on the spectrum. Then what I want to do is really understand their anorexia from the perspective of how I would work with somebody who's on the spectrum, as this is their special interest. Right now, they're really caught up in their calories and their exercise. So there's a drive, there's that OCD component. I would ask, the thing I would do is if you are around anybody that's doing TMS, because TMS has a component of their FDA approval for treating OCD. If that transmagnetic stimulation psychiatrist is comfortable taking on a low weight anorexic to treat only the OCD, perhaps when we treat the OCD, we may then be able to get them to start nourishing their brain better. And then when the brain nourishes better, then you can bring them on for neurofeedback for like ongoing regulation of the brain. But I in my practice here, I would not take on a patient that's at that BMI to do neurofeedback, because the brain needs to get fed first. And if they agree to increasing their weight in a very consistent way, I may consider it, but I'm going to wait for a while because, sometimes you have to feed them close to 6,000 calories for about 10 weeks before the weight begins to move. So the brain needs nutrition, brain needs food. And I'm not going to take a person on because that's very high risk.
That makes a lot of sense.
Yeah.
Okay, thank you. Let's see, we've had a couple of questions about neurofeedback for tinnitus and misophonia. Do you know of any evidence for those types of things?
Absolutely, absolutely, absolutely. In fact, I'm treating a patient right now with tinnitus. Yes, we do, because we in the neurofeedback world, we definitely always look at the origins, because so much of what we teach, what we work with, has biological origins to things. So for the person who has tinnitus, what we want to do is see what the origin is. Like one of my friends, he's a friend of one of my Rotarian buddies, developed tinnitus after he had swam in the ocean here in one particular area that they swim in, because there were some bacteria there that, like a bunch of them that swim together, ended up getting tinnitus from that. Mm-hmm. So you want to look at the origin of the tinnitus. And the person I'm treating right now, who just came this past week, she started a job, intense, demanding job, stress. She's an internalizer. So I know that as soon as her body begins to relax and she's not so tense anymore, and she's not holding all the tension, her tinnitus already started remitting a little bit in the first session. It did come back, but I told her, I said, we'll need to rewire the brain, because she just got too hijacked. So if it's very triggered by stress, triggered by sound, if you've got, I always ask them to get a very thorough ENT consultation first, so that we can rule out any physiological pieces underneath there. Yeah.
Okay.
Misophonia is also very treatable with neurofeedback. Very treatable with neurofeedback. Yeah. Very successfully treatable. I mean, imagine, the suffering that our patients with misophonia have. It's really So sad, so sad.
Okay, great. Then a few questions asking about it as far as cognitive impairment and dementia.
So, cognitive, so we have, we all know when we go to IMH, Dr. Bresnahan presents there. I love his workshops. I'm always there. I'm always taking furious notes. I read his books like crazy. So we know that with cognitive impairment, he also has started to begin to add neurofeedback as a treatment modality for the folks that he works with, where he's reversing cognitive impairment, right? He's doing a fantastic job. But it's not a single pronged approach. When I'm working with anybody with cognitive impairment, I will want to first see what's happening with their sleep. I want them to be seeing a integrative psychiatrist. I want them to be seeing an integrative naturopathic doctor, because I want a lot of the we always do. I have a number of integrative physicians I work with who do a lot of genetic testing, because we want to see where their APO4 markers are, and we want to be looking at dementia in the family tree and all of that. I have not worked with anybody with dementia, because by the time, you've got the proteins in the brain that have progressed to that level, we know even with cognitive impairment, the earlier we catch it. So that's why when we're doing lithium orotate and we're doing some of these things in our 50s and early 60s, that's so much better for our patients and their brains. I've worked with a lot of people who are in their 80s, 89, 90, who come in because they just want to feel better. And they're like, God, I didn't think that I would start sleeping through the night at this age. I assumed old age. So I've got a lot of folks I've worked with that are in the over 80 category, who begin to start to feel a lot more sharper, sleep better, are more alert, less anxious, have more energy in their body. And they're coming in kind of like as a self-care thing for themselves. So I would love for people to start embracing neurofeedback as kind of like a prevention modality. So anybody can do well with going for neurofeedback, because you're just improving the overall functioning of your brain and reducing cognitive impairment down the line.
Okay. Then a couple questions about using it for dissociative disorders.
Oh, magical. Oh my God, magical, fantastic, very, very successful. I just stay T3, T4. I stay there. I look for the frequency. I find the right frequency. And the groundedness that comes about, patients remain present, self-harm behavior starts to dramatically reduce. I also do a lot of right frontal for self-harm and all of that, the impulsivity that comes along with the dissociation. So no, extremely successful with dissociation. Yeah, very, very successful. It gives me so much hope when patients can start to feel like, and they'll say, gosh, I'm waking up in the world in a way in which I never have, and it's a little bit overwhelming. And so, in the sessions you do a little talking through, or I make sure that they're seeing either their EMDR therapist or they're working with a therapist. When I work with somebody where I'm doing exclusively neurofeedback, and I feel like they really need something addition to the neurofeedback, I'll be the first to let them know, hey, I think you would benefit from some counseling sessions or some psychotherapy sessions. And here are some people that I'm thinking about. So I'll make a lot of referrals out in the community, because I'm primarily working with the brain. I want to work with the brain.
Okay. Is there a difference in the approach with the therapy for something like PTSD versus eating disorders?
Yeah. There's a big difference working with PTSD. Different approaches when I'm working with ADD. Like I have a certain type of specific training that I do for the ADD brain that's different than what I do with PTSD. I have a specific training that I do. So again, within the neurofeedback system that you receive, that's part of the training you receive in your neurofeedback initiation as you do that, where you train in these regions for this and you train in these regions. Now, again, because we're generally in certain regions, like say, for example, if I'm doing T3, T4, I may be doing it for dissociation, but T3, T4 is also the site I go to when people have a lot of disruptions in their sleep. For example, they don't transition from one cycle to the next cycle in a in a smooth way, and they may have frequent wakings in the night. So I might be working on T3, T4 for the dissociation, but my patients will come in and they'll report, gosh, Dr. Kakaiya, I'm feeling like I slept through the night. I'm not waking up as much in the night. So there's all these added benefits that come about. But yeah, my approach for somebody, for example, my approach for somebody with anorexia would be very different than my approach with somebody with bulimia. My approach for somebody with Asperger's autism may be different than my approach in working with somebody with OCD or someone who has tics. Again, the big thing that I'm always going to be looking at before I get started with any neurofeedback is developmental trauma. If there's developmental trauma, I'm going to want to touch the trauma, because ADD might remit, anxiety might remit, depression might remit, because they might have been coming to me for ADD, anxiety, or depression. But if I know there was developmental trauma, that's what I'm going to start working with initially in order to get the brain to this really solid state to where they'll say, wow, I've been reading books again. Like I couldn't get into books. I'm reading books and I'm enjoying my books and I'm relaxing and I'm like more communicative with my family. And my husband says that, you know, I'm kind of lighter in my energy. I have patients. I kid you not, Heather. I have patients whose friends have asked them if they got a facelift.
Right.
I'm like, okay, because what happens is when we do neurofeedback, your patient's cheeks get flushed because there's so much more blood flow that's going into the brain. We're bringing that much more blood flow in the brain and they're doing that much work. So you'll find that their faces will be red, that face gets flushed because we're, stimulating the cerebral the cortex.
Wow, that's great. Okay.
So there's definitely on the way. Yeah, exactly.
Yeah, nice side benefit. Okay.
Yeah.
So there's lots of questions about insurance coverage.
Yes.
Is there anywhere?
I always have to fight with those douchebags, pardon my language. I work with teens a lot. I have to fight with them because so that's why 90901 is the one that tends to be. So if you're within network, then they will cover EEG biofeedback is what you'll call it. And they'll tell you they cover it, but then the next question you want to ask them is, what conditions do you cover it for? And they'll tell you specifically which conditions are inclusions and which conditions might be exclusions. So ask a lot of questions. If you're in network, which conditions are you going to cover for? And then chances are along the course of a dysregulated brain, depending on what the conditions are, chances are they might meet some of the criteria for one of the ones that they're going to cover, because they're broad enough to where, but there are some that insurance companies that will give my patients a run around. And then there's this sheet that's there that's telling them that we're not going to cover these. I'm like, why don't they give us that sheet at the outset? But what we have that's exciting finally, after all these years, is we finally have a group of practitioners, a group that has created a decent lobby. I think one of the reasons why insurance companies don't even know of us or don't want us don't cover us is because in our world, we've all just been busy being practitioners, and there haven't been enough group of us that have like rallied forward to be able to create the advocacy and the activism you need to do to go sit in front of those insurance companies and fight for a reimbursement for your code. So, but that's happening more now in the last 4 years or so. So more insurance companies are becoming more user-friendly to it. And I have quite a few PPOs in town here that will cover, but because I'm out of network, it'll cover about 50 to 60% of the fee.
Okay. Do your patients need to be able to describe to you what they need help with, or do you quote unquote read the brain and then treat accordingly?
No, when they come in and I do the assessment, I ask them, what is it that you want help with? And they'll say simple things like they may say, I want to be able to sleep better, or I'm just constantly agitated all the time, or I wake up, really sluggish in the morning. They may say a few things. because some of my neurofeedback actually that I do not do a QEEG on some of my neurofeedback machines. I don't do a QEEG. It's a very symptom-based neurofeedback. So I may do that, but so that's where my assessment is my actual clinical assessment is extremely thorough. I'll spend a couple hours, maybe even more than a couple hours sometimes, because what I want to understand, again, as I do that history, we are looking at sleep, we're looking at pain, we're looking at headaches, migraines, we're looking at physical symptoms, we're looking, my neurofeedback evaluation is actually a psychophysiological evaluation combined with a lot that I look at in terms of the genetic history. What's in the family? Do you have migraines in the family? Do you have OCD in the family? A very, very comprehensive evaluation. So anybody that's going to be purchasing my franchise is going to be taught to do that comprehensive evaluation, because I'm a big believer. I'm like this kind of like a detective, you know, especially because so many of our patients don't know about the MTHFR genetic mutation. And, you know, when we know that OCD will have it, Asperger's will have it, you know, and how, do they have single allele, double allele? All of those things are things I'll start educating my patients about. And if they want to get the extra testing done, we do. But if they are okay with it, you know, one of my naturopathic doctors or my integrative doctors will tell them about methylfolate, and they may just start on the methylfolate right away. And that starts to calm down the brain as we start the neurofeedback. My go-to has been that when I have a new patient that starts with neurofeedback with me, I'll often only do the neurofeedback intervention first for the first month to 6 weeks before we start talking about any supplements they might be adding or any other things they may add in there, because I don't want to have confounding variables that come in. Then they're like, well, I'm not sure if because I started my omega-3s that I'm feeling a better focus. Maybe it's that, maybe not the neurofeedback. So I just do the neurofeedback solidly for about 6 weeks so they can start to experience the difference they feel on the inside. And then we may talk about other micronutrients and other things that they can add.
Great. Okay. Do you do any work specifically with the vagus nerve?
Yes. There were 3 little Girl Scouts of mine, 2 Girl Scouts and 2 adult women that I just treated through COVID for the vagus nerve. Absolutely. And there's a lot that can be done. And again, you know, we in neurofeedback, some of the systems will, and the system that's in my franchise also comes with a biofeedback monitor with it too. So I'm always coaching my patients on their breath techniques and their breathing. So the system that comes with me, with my franchise, is one that's going to have a biofeedback component to it too. So you're going to be combining neurofeedback and biofeedback at the same time. And the vagus nerve function really responds well to neurofeedback and biofeedback. I've never done, the patients I had this past year, I didn't do any biofeedback on them, just did the neurofeedback, and they just really have responded so well. And I think I did 20 sessions. 20 sessions.
Okay. Can you differentiate between the mechanism of action in neurofeedback versus TMS and DCS approaches?
So TMS is magnetic. DCS is magnetic as well. Neurofeedback is electrical. That's the big difference between the 3. So I'm stimulating the electrical circuitry. TMS is a magnetic resonance, and DCS is magnetic as well.
Okay, perfect. Is neurofeedback effective for chronic pain?
Yes. I could go back to my chart. I can actually go back to my chart that shows all the conditions I treat, because I have one of my most successful, I kid you not, one of my most successful group of patients that I treat are patients with fibromyalgia. I have so many patients with fibromyalgia that I treat, and they respond so well. I have a ton of doctors who send their fibromyalgia patients to me because they've seen the changes that we have. So yeah, fibromyalgia, I guess I don't have, yeah, I have pain conditions. Yeah, we have very positive response with pain conditions, extremely. And then, we can start getting patients off these medications and they don't have all these side effects and you don't have your dependencies and, you don't have the rebound effect from all your medications because what we're doing. So I have, patients who have, sciatica. I've treated a lot of patients with sciatica, but just general pain conditions, whether it's from their arthritis, it could be migraines, it could be muscle pain, muscle aches, different kinds of pain conditions. And what I found is my patients who have concussions tend to have a lot of pain conditions that come along with it. So when I start treating the concussions, the headaches, the migraines, the pain, all of that are some of the things that start to remit first at the beginning. Yeah.
Okay, great. Well, I think we're going to go ahead and wrap it up now. This has been a fantastic presentation, great questions and great answers to questions as well. I know there's been a lot of interest in asking about your recommendations for local providers and your franchising as well. Would you prefer people email you? I know you had your email address up on that last slide.
Yes. And, I just looked at one of the questions. What's really fascinating is that what we know when you dig into some of the neurofeedback literature, every literature talks about how there are increases in IQ points with neurofeedback. Again, it's a no-brainer. And the reason is it's a no-brainer because the whole brain is functioning so much more efficiently. And what I would love to do, because I am very committed, I do a lot of service projects in my community because I'm a Rotarian. I'm service above self. Even before I became a Rotarian, I was doing a ton of free stuff for members in my community. I'm very active in the human trafficking world. I work a lot with trauma. What we do in our practice is all of my clinicians know that each of us at any given point may have one or two pro bono patients that we work with. So when I am going to be working with my franchisees, I make it very clear with them that part of being like a real agent of change in your community is to give back in some big, significant way possible. So for us to think about that and writing grants, if people would start writing grants for our refugee populations, because we have so many people that are so traumatized that we do need to do this brain treatment. So you may end up hiring like a master's level intern who writes some grants for you for neurofeedback. There are so many grants that are available through the Department of Justice, Department of Defense, sorry, my bad. Department of Defense that are for PTSD, for trauma, that are grants that can be written. And that's how you can bring neurofeedback into some of your nonprofit clinics and things like that.
Wonderful. Okay. Well, thank you again for a fantastic presentation. Very interesting. And we had a very happy and engaged group, I think. So we really appreciate it.
Good. Thank you. Thank you, Heather. This was fun. And please, anybody, those of you, I see all the lovely questions we had. Please do not hesitate to email me. I'm utterly happy to answer your questions. I want you all to become user-friendly to neurofeedback. Yeah, buying my franchise would be a thing, but most importantly, I want each of you to start getting comfortable with neurofeedback and introduce it into your practices in some form or another. Put it on your prescription pad, please.
Wonderful. All right. Thanks again, Dr. Kakaiya.
All right. Take care.
All right. Thanks for joining us, everyone. Good night.